Comparison, this is a patient where when you calculate the chamber stiffness constant, the stiffness is increased and they have problems with elevated diastolic pressures. We can look at pressures in the cath lab invasively with regular fluid-filled catheters, if you would, in the left ventricle, and these are reliable to look at pre-A pressure and end diastolic pressure. This is taken from a patient with hypertrophic cardiomyopathy with shortness of breath, and just looking at these with a pre-A of 24 and an EDP in the 30s, you can tell why that individual is short of breath. If you do a cardiac cath in someone who's short of breath and you have these nice recordings of pulmonary capillary wedge pressure showing the A and the V waves, you can appreciate that there is the mean pressure in the wedge position, and it's in the high 20s, again proving that at rest that individual has issues, and it is related to the high filling pressures. So all of that is wonderful, but then the question comes, can that be studied non-invasively? And a lot of developments happened in the field of echocardiography, starting with MO, 2D. Pulse Doppler was a big development, and individuals were able to use the existing, at that time, ultrasound systems to get mitral inflow. This is early work from here, from Dr. Quinones, 1985, looking at the validation of these pulse wave Doppler velocities. It was recognized that these velocities reflect the rate of filling of the ventricle, and if you combine the velocity with the area, then you can calculate volumetric flow rate. They used volumetric measurements of the ventricle with ventriculography, and then they looked at the rate of change in volume with time, and you can see here that what you get with that derivative of volume is very similar to what you get with pulse wave Doppler technique, with excellent correlations between the two. So that proves that what is measured is reflecting the filling rate of the ventricle. The mitral inflow, which was and has stayed and remains a cornerstone when we look at diastolic function assessment, was then sort of investigated in depth. And that's an early publication from Chung and Wayman in a dog model, where as you increase the left atrial pressure, as you see here, that mitral E velocity goes up. What happens if the relaxation is made worse? And that happened with inflating a balloon that increased the pressure in the aorta. The time constant of LV relaxation gets longer, and that E velocity drops. So that shows us the two variables in the dog model that affect mitral inflow. Can this be made use of clinically? Dr. Appleton, Liv Hatley, and Richard Popp had a very well-received publication, also frequently cited, in 1988, looking at the determinants of diastolic function in humans. They had wedge pressure recordings and left ventricular recordings, and if you look at this pressure curve for the atrium and the ventricle, you can appreciate this minimum pressure. Then there is a rapid filling wave in the LV pressure, rapid rise, if you would. Patient has a large A wave, but there is a time when the ventricular pressure here exceeds the atrial pressure, and that results in flow from the ventricle towards the atrium. And of course, that patient has a restrictive filling pattern. So paying attention carefully to mitral inflow beyond just the peak velocities can be very rewarding. Another signal that was recognized, came into a lot of interest, and has made it back in the 2025 guidelines, is pulmonary veins. This is work from Dr. Nelson Schiller that was published in 1990, taking patients who are undergoing cardiac surgery, and transesophageal echo was used to record pulmonary vein flow. You see flow from the vein into the atrium during systole and during diastole, and then with atrial contraction, it is flow from the atrium to the vein. When left atrial pressure goes up, the proportion of flow during systole goes down, and relatively the proportion of flow during diastole goes up. So a reduced flow in systole compared to diastole goes with a high left atrial pressure. point of caution, these were patients with cardiac disease. They were going for surgery. So a similar pattern to the one that you see here can be seen in normal young individuals, though. Then Dr. Roosevelt and Liv Hatley had another famous publication in '93, still looking at the pulmonary veins, and you see here that atrial reversal velocity being recorded, and you see that it lasts longer than mitral inflow. That corresponds to a high A rise in ventricular pressure and an elevated EDP. And here the time difference of 65 milliseconds is quite elevated. The cutoff is 30 milliseconds. So that's another useful index that we rely on when we want to speak specifically about late diastolic pressures and LV EDP. Then came the mitral inflow velocities in the late 90s. And what the mitral inflow velocities record the annular behavior. So during systole, the annulus moves towards the apex, and then during diastole, it moves away from the apex in early and in late diastole. That early diastolic velocity A for annular, that was the terminology used at that time, was then investigated how it relates to diastolic function properties. And this is work in a dog model where venous return again was altered with IVC, a tightening of a stitch, if you would, around the IVC to decrease the venous return in a normal dog. And you see here with decreased venous return, the velocity decreases, both amplitude and, of course, time velocity integral. That proves that it is affected to some extent by loading conditions. On the other hand, when esmolol was on board, so that's a drug that suppresses relaxation, makes it worse, and you do the same thing, you don't see much of a change in the velocity. What happens if we alter relaxation by giving dobutamine or esmolol? That velocity goes up with dobutamine, that enhances relaxation. Notice the faster heart rate, and then it slows down if you give esmolol, which slows the heart rate and suppresses relaxation. When you put things together and say what are the determinants of this diastolic velocity, early diastolic velocity, whether recorded at the lateral side of the annulus or the septal side of the annulus, it is left ventricular relaxation captured by that time constant we talked about earlier, negative dp/dt, how fast the pressure declines, as well as minimal pressure, which is affected by relaxation and by the suction properties of the ventricle. A more insightful slide is shown here. It looks at the behavior of that velocity against the transmitral pressure gradients in experimental stages when the relaxation, if you would, was not impaired. Time constant defined by a time constant less than 50 milliseconds. And here you see the solid line and the solid dots showing a direct relation. So that annular velocity goes up as the transmitral pressure gradient goes up. But if you go to the stages where relaxation is impaired, you see that interrupted line and the open circles showing no relation with the left atrial pressure. You may ask why this different behavior depending on whether there is disease or not. We'll come back to that in a short while. Similar to that experiment that you saw, this was the original publication from here in 1997, taking patients, this time all of them with cardiac disease that had indications for cardiac catheterization with a wide variation in wedge pressure from 5 to 42, and you see that scatter plot similar to the experimental stages where relaxation was impaired, no relation with wedge pressure despite a very wide range. And we put things together and you say the mitral E relates to the left atrial pressure, as you saw in Dr. Chung's work, and it relates inversely with the time constant, and so we can see that E is directly proportional to the ratio of atrial pressure divided by the time constant. Since the time constant of LV relaxation relates inversely with E prime, as you saw in the studies I showed a few minutes ago, we can remove the time constant and put in its place 1 over E prime, and we can rearrange to see that E is directly proportional to the product of pressure and E prime velocity. Because the interest is in left atrial pressure, we rearrange the expression and we come up with the E to E prime ratio as an index of left atrial pressure.